for this today's webinar on cutaneous dermatomyositis disease area and severity index, known as CDASI, through real life examples. Chairpersons for today's session are Dr. Mary Augustine and Dr. Ramnath Mishra. Dr. Mary Augustine is Professor Dermatology at St. John's Medical College Hospital for almost 1.5 decades. And she graduated from St. John's, Bangalore, and she has done MD Dermatology from Government Medical College in Kottayam. And she has more than 2.5 decades of teaching experience in dermatology. And she is truly one of the most loved teachers by the graduates and the postgraduate students. I've seen her teaching on the ward rounds, and which is just too good. She has extensive experience in immunologically mediated skin disorders and in rheumatic diseases, and she's our go-to dermatologist whenever we are in trouble with any of the patients. The other chairperson for us today is Dr. Ramnath Mishra, and I don't think he needs any introduction to the audience in India. He is currently the Dean Research and Development at KIMS Bhubaneswar, and he is my teacher from SGPGI, and I trained under him, and I'm proud to say that. He has actually trained a generation of clinical immunologists and rheumatologists for more than 3 decades. His clinical pulse and wisdom has fine-tuned our outlook in dealing with the complex clinical situations. So I'm very proud to introduce sir. And he's been the past president of Indian Rheumatology Association, and he has numerous accolades to his name. May I request Dr. Ramnath Mishra to please introduce Dr. Victoria Worth.
Right. Thank you, Benita. Professor Victoria Worth, who is Professor of Dermatology and Medicine at Perelman School of Medicine, University of Pennsylvania, and she is the Chief Division of Rheumatology, Philadelphia Veteran Administrative Hospital. She obtained a medical degree from the Johns Hopkins University School of Medicine, Baltimore, and did residency in internal medicine in Northwestern Memorial Hospital in Chicago, Illinois. She did her dermatology residency and immunodermatology fellowship at the New York Medicine in New York, funded by NIH. She joined the faculty at Penn in 1989. That's a long time ago. And she has almost devoted her entire academic career in autoimmune skin disease, including cutaneous lupus, dermatomyositis, autoimmune blistering disease, with a focus on improving of autoimmune dermatologic disease. She has developed and validated tools that we now use in many international trials, improving current and new therapeutics. She is a co-founder of the Dermatology Society and a previous president of this group. She is a co-founder of the Medical Dermatology Society and is a recipient of their Lifetime Achievement Award. She has again numerous awards, including the Lifetime Achievement Award for the Medical Dermatology Society and many others. Women's Dermatology Society, American Skin Association Research Achievement. And actually, it's a privilege and a proud moment for all of us to listen to her today, where she is going to teach us through real life cases how to use tools in assessing cutaneous disease activity and damage in dermatomyositis. It's going to be very important to us.
Your video is off.
Thank you, sir. I'm going to stop sharing now, and Dr. Worth, please start sharing your screen.
Okay. Let's see. I think this will do it. All right. So let me see if I can put this on presenter mode. Up there we go. Okay. So I'm going to approach this a little bit like a training session, which I think will be helpful for what you're trying to do and for me to explain things to you. The CDASI was developed to systematically assess the extent of cutaneous disease in patients with dermatomyositis, and it really looks at extent and severity. The validation was extended to adult dermatomyositis, JDM, and also with dermatologists and rheumatologists. And we've done a lot of validation studies. Some of them I've listed there. It's a tool that's been really available now for well over a decade. And a lot of validation in terms of looking at responsiveness and inter-rater and intra-rater reliability, and so on. And I will say we also did it, and we also tested in adult DM and JDM. We also tried to include neurologists actually in our validation studies and found that there was much more variation in their assessment. Some were excellent and some were not so excellent. So it's important that people be properly trained as well in the instrument. So I think this is a great opportunity for us. So what I will tell you is that the CDASI response correlates with things that we know are important in dermatomyositis, including things like the type 1 interferon signature, CXCL10, which is a type 1 interferon upregulated chemokine ligand. And what this is showing you is if you look at the gene signature, when you have very low skin activity, the interferon signature is quite low. And when it gets above a certain level, which we now recognize to be more in the moderate, starting at the moderate level, that's when you start to see a correlation between, or that the CDASI activity is positive in people who have a gene signature. So what's interesting is that when you look at interferon beta in the serum, you can see that there's a very nice positive correlation, which is statistically significant between CDASI and serum interferon beta. And then also, if you look at the CXCL10, there's also a linear relationship. That was not seen with interferon alpha. And so it's very interesting that the things that we think are drivers for interferon beta, for dermatomyositis, are correlating pretty nicely with the skin activity. We've also done studies that have looked at people that are responders based on a 5-point change in the CDASI, which was determined from a physician VAS score of improvement. And here you can see, and you're looking at an emotional subscore, that when patients improved in their CDASI between visit 1 and visit 2, that their emotional subscore also went down. And that was something we actually did not see in the non-responders. There was no change in their quality of life. So we think that this can correlate pretty well with the emotional subscore and also the symptom subscore for patients with dermatomyositis when they have improvement in their skin. So in terms of designing it, we wanted to be quick to use, a high inter-rater and intra-rater reliability. And this means a few signs that we would look at, including erythema to reflect activity and dyspigmentation to reflect damage, and no attempt to assess percentage clinically, because sometimes you can have very focal involvement that's really significant, like Gotrins on the hands, and that's going to be a very small percentage. And so we did not want it to really, because it can be a somewhat, spotty disease, we did not want surface area to be the whole driver. So we rate disease activity and damage at 15 anatomic sites, and that's the sites up here on the left, and same thing on the right-hand side of the tool. There's a separate activity measure and a damage measure. The activity is the whole left side of the tool. The damage is the right side. When you add all of this up, you end up with an activity score at the end of the day, and a damage score over here when you add up these columns. And we know that mild disease activity is less than 14, and then moderate is greater than or equal to 14. We also know that a 40% improvement is what's important from a quality of life perspective for the patients. So I'm just going to go through some cutaneous findings. We've really tried to focus the areas that were captured based on the common things that we see. So we want to be able to capture the change for these things. And so here we have Gotrin sign with erythema over the joints. Here we have also Gotrin sign. So we want to be able to capture these, and we do, and I'll show you how. Here you can see periungual erythema for sure. And so these are all things that are important to be able to capture and to see if they improve in the setting of for instance, a trial. Here you can see there's some papules, and so that will lead to a different type of score. It increases the score, which we'll talk about how that is. But it's important to identify whether there's just erythema or whether you can also see papules in these areas. We all are familiar with the heliotrope, and around the eyes here is another area that we try to capture in terms of erythema and scale. Very often, and I'm sure that you notice this, there's dyspigmentation in the skin, and that can make it much harder to see erythema. However, what you can see to some extent is like scale here. And very often at the edges, one can see some erythema where you might not be seeing it right in the middle of the dyspigmentation. So it's really important to carefully examine, because pigmentation is really more of what we call damage as opposed to activity. And what I will tell you is that unlike in rheumatologic diseases where we think that damage does not improve, like when you have joint damage or from any disease, it turns out that the skin, even with the dyspigmentation, can improve. And so damage is there because as the activity is causing damage, but gradually the pigmentation can improve. So that should not be a problem, but you just need to realize that it behaves differently in the skin. And I'm pretty sure that can happen systemically. It's just much harder to evaluate in terms of what we call damage for other rheumatologic indices. So anyway, I think you can see some erythema, you can definitely see scale. So there's activity to capture here. But if you have a patient that you're putting in a trial and all you can see is pigmentation, that's probably not the best patient to put in the trial, because you're going to have a pretty hard time capturing improvement. But if you can see scale or you can see erythema, as you can see here, then I think that's fine. But that's something I think is really important to consider, especially since many of your patients will have some element of pigmentation also. This is a V of the neck. Here you can see erythema as well. And this is a pretty common area for involvement and one that we capture with the CDASI. Here's the Shaw sign, so upper back. Posterior neck is a separate area. The scalp is clearly, it can be involved, and photosensitive at the arms, obviously. So this is what we consider, though, the upper back and shoulders as the Shaw sign. Mechanics hands, a scale, and sometimes erythema on the often on the lateral digits. You often have scale, as you can see here, and we'll have some examples that I can go through with you. But this is something that we also capture. Also the Holster sign, which we see very frequently, and that's also captured. Here you can see erythema over the elbows and knees, and this is Gautrins off the hands in the CDASI, so we'll be looking at that as well. One of the things you have to decide is this increased skin markings due to just normal variant for the patient, or is it like canification, like what we see from somebody rubbing because it's itchy? And so it does require some really careful examination to try to figure that out. Then we also are able to capture if somebody has visible telangiectasias. That counts as a higher score than just erythema. And so it is important to recognize that feature as well, whether it's telangiectasias or hemorrhage, it can be captured. Now, in terms of the vocabulary for the CDASI, the erythema is either pink, red, or dark red. The scale is either scale or crust. And then there's erosions and ulcerations that can be captured. And then poikiloderma is dyspigmentation in telangiectasias. And these are telangiectasias are typically not going to be readily reversible, and they're considered a part of damage. However, I will point out that many patients have telangiectasias and erythema, and it can even be hard to tell the difference. And so you have to really carefully look to assess whether there's actually activity or whether it's more this damage component. And you can have both, as I said. And I think a lot of times it's why you don't want to have to say that somebody gets to clear, almost clear, in terms of the response to a drug, because that may not happen if there's residual telangiectasias, and it's hard to tell the difference between background, pink erythema and telangiectasias. So it's just important to realize that you may not get down to a CDASI of 0, but, and this may be one of the reasons why. And then calcinosis is another item that we put in more the damage side. So this is more the activity side. This is more the damage side. And so this is looking at pink, this is red, and this is dark red. And so you can see the different colors. And I admit that in darker skin, it's going to look a little bit different. And so it's important to, I think, calibrate to darker skin as well. This is scale, and this is more crust. And they can both be present, as you can see here. So this is more the white kind of material here, as you can see. But then if it's more serous drainage and crusting like this, where there's more of an erosion, then this would be what we would consider to be crust. Then you can also get erosions, such as here, and those would count also in a separate part of the score, which we'll talk about. And then we have ulcers here, which can be full thickness with loss of epidermis. And so this is an ulcer. So these are also captured. Now, in terms of the damage side, so here you can see that there are telangiectasias here, and this is all, again, damage, and you're going to capture that on the damage side of the CDASI. And then you can see dyspigmentation with hypo or hyperpigmentation, and that's really common as well. And so that's also captured under damage. And calcinosis can be either endophytic or exophytic, and you're going to capture that on the damage side as well. It's sometimes hard. I mean, you can't see it necessarily, so you have to almost feel. Often the patients have to point it out, and it's just a matter of, is it there or not there in the body surface area that you're examining? And so I think calcinosis is pretty hard to evaluate in a lot of times, but I think it's important to capture it. So this is what the CDASI looks like. And here you can see the top part of the CDASI. So we're looking at things like scalp, malar area, periorbital, rest of face, V area, neck, posterior neck, upper back and shoulder, rest of back and buttocks, abdomen, lateral upper thighs, rest of leg and feet, arm, mechanics hands, dorsum of hands, and Gotrin's not-on hands. So it's really important to understand these different anatomic areas, because that's what we're going to be scoring in terms of the degree of erythema, whether it's absent, 0, pink, red, or dark red. And the scale is either absent, scale is a 1, and crust-like lichenification is a 2. Erosions are either absent or present, and then poikiloderma is either absent or present, and then calcinosis is the same thing. So the bottom of the instrument, the 1 page, is Gotrin's on the hands. And these can either be absent or pink, dark red 2, or rather red is 2, and 3 is dark red. And if there are papules present, then we double the score. So what we typically write here is, for instance, if we have red papules, we're going to write 2 times 2. And if there's an ulcer, that's a 1, otherwise a 0. And then we're also going to capture for the Gotrin's area, is there dyspigmentation or is there evidence of scarring? And that would be measured here as a 1 for dyspigmentation, and scarring is a 2. The periungual area, 1 is pink or red erythema with or if you use a microscopic kind of approach, one could see telangiectasias, but not visible with the naked eye. So that's a 1. And then visible telangiectasias is a 2. Then, can you put yourself on mute? All right. And then alopecia is either absent or present is a 1. So you can see here you're adding up a total activity score and here a total damage score. So what we do with the CDASI is we rate the worst area for each body area listed in the CDASI. And so in other words, some lesions might be pink and others are red in the same body surface area, say the arm. You're going to rate the worst area, which might be the red then if that's the worst area. And so it's just important to realize that we try to make it simple. We're not trying to average the pink and red. We're just saying, what's the worst area? That's what we're going to measure. And how does it change over time? So these are the papules, again, where you're going to double the score. We talked about this already. And again, it's going to be the worst area for the hands. So if somebody has mostly pink macules, but they have a red papule, you're going to count the red papule. So this is some examples here with the scalp. You can see there's erythema here. It's pink. There's no scale. So there's nothing else to capture except pink erythema. And there's also an element of asking the patient, have they had more hair loss than usual in the last 30 days? And if they say yes, then that's captured as a 1 on the instrument. And then again, there's a scalp, and you can see pink erythema, you can see scale, there's nothing else to capture, but most likely the patient will report that there's been more hair loss given the extent of hair loss here. And so this is a very subjective thing, but we feel important from a patient perspective because it really bothers them. And sometimes it can be hard to know if the hair is, you want to do only attribution of anything on the skin to dermato. But if you're attributing it to dermato, then you're going to want to capture that self-report. And it's only 1 point. Okay, so here is upper back and neck. And you can see that we're calling this red. If you thought this was telangiectasias here and here, which you're gonna have to look at it pretty carefully, then you would capture that under poikiloderma, but otherwise you're just capturing erythema, and really there's nothing else to capture here. So these are the anatomic landmarks that we use to try to determine upper back. And so we're going to follow the spinous process of the scapula around here and back up this area. So everything up in this area is going to be upper back. Everything here is going to be neck. And everything below this area is going to, for instance, all of this is going to be rest of back. And so it's just important to think about that in terms of the anatomic, in order to choose the right anatomic area to rate. If somebody has a lesion that extends like from the neck all the way to the upper back, you're going to measure, you're going to record it for both areas. So, usually it's going to be pretty confluent, but if it happens to be an area that there's something here and then it goes into here, into upper back, you're going to want to capture in both surface areas. So here again, it's what it looks like. And so here you can see that there's erythema that is, red. And here we have a lot of areas to look at, right? We've got the neck, we've got the upper back, and then we've got rest of back. And so all of those are, and I will be the first to tell you that on pictures, it can be really hard to assess degree of erythema. I almost don't try very hard because it has so much to do with the monitor and the lighting and so on. So I think if this doesn't look red to you in the worst areas, don't feel bad. There's so many variables that go into looking at pictures. But we categorize this as red on the posterior neck, on the upper back and lower back. And otherwise, there was some dyspigmentation that you can see that we attributed to the dermatomyositis, so we captured that as a 1. And then here, you can see that there's involvement in the malar area. Typically, you'll get involvement of the nasolabial fold, but maybe not so much here. And so the anatomic variant that we use here, for nose, because you can see here it's scalp, malar area, periorbital, and rest of face. So it's very important to also look at the anatomic area for malar area versus rest of face. And I'm going to just see here, this will be easier to see on this one. So what we do is you take a line from the lateral canthus and all straight down to the lip, cross, up the nasolabial fold, under the nose, down the other side, over to the lateral canthus area, and then straight up. And everything that's medial to that is going to be malar area, nose malar area. Now, the area under the nose, is, if you notice, I drew a line here and then down here. So this area is considered rest of face. The chin is rest of face. Lateral to this line on the face is rest of face, and everything on the forehead is rest of face. So it's really important to kind of have that identity and to be consistent about that. And I would say all the erythema here seems, at least on the malar area, is not, you don't really actually see it beyond this line. Or if you thought you did, then you was, if you're seeing anything here, then you would capture, but otherwise you might only capture this as nose malar area. And although there may be things here which are rest of face that you're going to capture for rest of face. So it's just important to kind of understand that part of it. We called the color pink, and there was really nothing else here to evaluate. So here, if we're looking at the periorbital area, and this is more red in the worst areas. And so we would call that. And then if you look on, and again, it may be hard to see it a little bit, but there are some telangiectasias here. And so that would be captured as part of poikiloderma as a 1. But those are the only things. And you'll see that erythema is really a huge driver for capturing changes in the skin. And then here we're looking at the rest of the face in the malar area, and the color is more pink, not red here. So if you look at the cheeks, if you look up here on the forehead, but there's really not much else. So it's a 1 for pink, but everything else is kind of not there. So this is looking via the neck, and we're thinking it's red. And if you think that there's some dyspigmentation in here, then you might capture that under poikiloderma. And so here we're looking at the malar area and V-neck. So this is the malar area, more typical involvement of the nasolabial fold, and the V of the neck. And these we would consider to be dark red, and everything else is there's some poikiloderma if you see telangiectasias or dyspigmentation. And so what I will say is, if somebody has just skin and amyopathic DM, one of the things that we see very often is, for instance, in the lupus trials, some patients have dermato, but they're called lupus. And so there's certain clues to think about, for instance, the more violaceous erythema, and also maybe much more frequently involvement of nasolabial fold, but they may not get muscle involvement. And so, and the drivers, the cytokine drivers are different. So it's really helpful to be able to differentiate between them. And so this is looking, again, dark red. This is on the abdomen. And you can see that there's a little bit of poikiloderma, some lighter areas here. So that we're capturing as a 1, and otherwise dark red. So here's Gotrans, and we're saying it's red erythema. You can see over here, there's some crusting and maybe some lichenification with increased skin markings here. So we would capture that as a 2 for scale, but there's also erosions, and here is an erosion, maybe here an erosion. So anyway, this would be called 1 for erosion ulceration, and nothing on the damage side. So the hands can give you a lot of points, because that's a frequent area for involvement. But between the Gotrans and the mechanics hands, there's a lot to measure there. And then the other anatomic area we look at is dorsum of hands. And so again, to define the anatomic area, that's the area that's not over the joint. So it could be between the joint, like here. It could be behind the MCP in this area. And so it's between joints and then posterior to the MCP. So we're seeing that the worst area for dorsum of hands here, it looks red, and that's really the only thing to capture. And as you can see, many areas are not red, but we're capturing the very worst area. And so this is looking at the Gotrans now on the same patient. And here again, you can see that it's red. Now on pictures, it's almost impossible to tell if there's if it's just macules, meaning flat, or papules, meaning the bumps. And it's really hard, but if there were bumps here, then you would double the score. It would be 2 times 2. And I often write it out that way. And there's no damage, no erosions or ulceration. And then here it's dark red and they're papules. So 3 times 2 is 6. And here you can see ulcers. So you're going to capture that for sure. Erosion ulceration is present. And then there's some pink around here. So I'm capturing that with a pink. And then here there's some scarring, probably an ulcer that has healed. And I'm counting that as a 2 for damage. And the idea being that if it would be just this pigment, it would be, if you just had this, it would be a 1. But with the depression and the scarring, it's a 2. So then the other anatomic area is Gotrans, not on hands, so over the elbows. And here you can see red erythema. There's certainly scale here. I don't know that I would say there's any lichenification, but so we're capturing that scale as just a 1. No ulcers and really nothing else to capture. And this is the knee again, and here it's red. If you consider this increased skin markings due to the dermato, that would be a 2, and then everything else is normal. So this is livido, which you can see in dermato, you can see it in lupus, you can see it in lots of things. So it's not a dermato-specific type of skin lesion, so we do not capture that. Excuse me. So if you see this on a patient, we're not capturing that with the CDASI. And it's considered more of a non-specific finding. And then here, so we'll go through some examples. And if I wasn't giving a talk, I would like ask you what you think. So maybe you can think about it. And then I'll tell you what my thinking process is. So we're going to be measuring Gotrins on the hand. And I think this looks pretty much on the red side. If it's elevated, it would be 2 times 2. There's some erythema in the periungual area. But we're just talking about the Gotrins. So it's 2 for red, and then if it's papules, you'll be doubling the score, and that's really all I would capture here. Now, what about here in the periungual area? And the question is, do you see any telangiectasias, or is there just erythema? But I'm going to argue that I can see some telangiectasias here. There's probably some dropout here, and there's erythema here. So if you just had this, it would be a 1 for the nail fold, proximal nail fold. But because of this and dilated blood vessels, it's a 2. So visible telangiectasias. So here the question is, what's going on around the eyes? And I think we'd all agree there's something, some erythema here, and I'd probably call that a 2. But what's really, I think, important to capture here is the fact that there's increased skin markings. Likely the patient is really itchy and rubbing. And so this is going to be a 2 for lichenification. And if it was just scale, it'd be a 1, but there's lichenification. And then ulceration, not there. And I don't think there's any damage. So this is how we scored this one. And if you have individual cases you want to discuss later, I'm happy to go back. So here you can see somebody who has involvement on the forehead and of the scalp. And you can see this lesion kind of extends between both areas. So you're going to capture it in both areas. And I think that you can see that there's a degree of erythema here. I don't think I'm seeing any scale. And so you're going to capture rest of face and scalp, and likely, at least on my monitor, I think it looks red. You're going to ask her about recent hair loss in this area. And if so, then that would be a 1. So this one's a little more difficult, right? Because there's telangiectasias here, so this is going to be damage. But there's also erythema in the scalp and also on the rest of face area, off the scalp. And so you've got both damage and activity in the same area. And we captured this as red erythema. In the worst areas, I think you would argue maybe this could be red. Excuse me, and in the scalp. And then there was also this poikiloderma with the dilated blood vessels. And so we're calling that 1 for poikiloderma. So here we're actually looking at the dorsum of the hands. And you can see that there's a lesion here. There's also scale. There's erythema. You'd have to grade the degree of erythema, but this would be considered dorsum of hands. And we graded the erythema here as a red. There was scale, but no damage. V of neck. So here, degree of erythema is red, and otherwise we did not see much. If this, to me, this whiter areas look more like normal skin color. So rather than calling it dyspigmentation, I would just say it's reverted back to normal skin or never been involved. And so I'm not going to count that as poikiloderma. So this is largely red erythema on the V of the neck. And then this is on the elbow. And so this is Gotrins not on hands. And you're going to capture this as probably red. I mean, this is a tough one actually to grade, I would say, but we called it red. There was some scale, but it's a little hard to tell on this power, I think. And then the more important thing is just to point out that there's some darker skin colors, which is poikiloderma, and also some calcinosis. So there's a lot to capture on this area of Gotrins not on hands. And then this is the knees. And degree of erythema you're going to capture. There's maybe some dyspigmentation. We're calling this dark red, no scale. And we actually said no poikiloderma. We attribute this to activity. But again, I think it really becomes trying to understand what's activity, what's damage. And I wouldn't argue if you thought some of this dyspigmentation was part of damage. But there's clearly some activity going on here as well. And then this is looking again at the knee and the elbow, and you're going to look at both when you're looking at Gotrans not on hands, and you're going to grade the worst area, but they're both reds, so that's good. And this one has scale, but this one has lichenification. So you're going to say that it's red and that there's lichenification, and there's nothing else to grade there. And then here we have a lot to grade on this hand. And so what we can start with is the dorsum of the hands here is pink. And so we'll probably need to score that. Gotrans on the hands, so that looks pink. Oops, sorry. That looks pink, but no papules, so that would be a 1. And if you look in the periungual area, which I blew up over here, you can see that there's some telangiectasias and maybe some hemorrhage, and that would be a 2. It's not just erythema. And so this is how we graded it. Pink for dorsum of hand, no papules over the joints, and nail fold telangiectasias are 2. This is a kid, probably pink. Again, lots of areas to grade here. And so dorsum of hands, well, actually for the dorsum of the hands, we called it pink, and maybe in this area, it's kind of a little hard to tell actually, but we felt that it was probably pink, and I'm not sure I can identify, maybe here, pink, and a little bit here. In terms of the Gotrans, we said more red, but they're not papules. And then periungally, there were telangiectasias, which I think if you look closely, you can see like right there and right here. And so that was a 2. And then clearly in darker skin, you have to sort of recalibrate a little bit, but you can see that there's erythema here, there's dyspigmentation. And so we called this red in this color, in this skin type. But one of the things that we know is that people tend to be coded lower when they have darker skin in terms of the degree of erythema. And the good news is that because we're capturing multiple body sites and with the same investigator, it hasn't been a problem. But if you start changing investigators who are assessing things differently in darker skin, that could become a problem. So I think it's really important to try to have the same investigator assess patients, and also to take into account that there's background, darker skin types. But there is poikiloderma here with the dyspigmentation, and there's clearly, we think, red erythema. And I don't really know that I can see scale, but if you saw scale, then you maybe here you would call it a 1. Now, there's a lot of references. If you look at CDASI, I'm just highlighting a couple of them here. And there's a couple more here, and there's been more all the time. Again, extending validation. And then the other thing that we've done is we've looked at what's a meaningful response from a quality of life perspective. And we know that from 14 and up, a 40% improvement is going to capture meaningful improvement from a patient perspective, quality of life perspective. And so this is just to show you a very small study that we did with a drug, glinabacin, which was basically a 22 patient study. And we had a placebo group and a treatment group. And at 16 weeks, they were statistically different, pretty small number of patients. But what happened was at 4 weeks, we doubled the dose of the drug. And so you can see the placebo effect in the drug were exactly the same for the first 4 weeks. And then when we upped the dose, immediately the curves kind of separated. And this correlated nicely with the patient activity VAS and Skindex symptoms and PROMIS 29 pain. So, and this is again, the treatment arm here in blue and the placebo arm in orange. And you can see the curves nicely separated and it seemed to correlate pretty well with the changes that we saw in the CDASI. So I also wanted to mention that there was a IVIG article that was published in the New England Journal that showed that the TIS showed improvement in dermatomyositis, and these patients had all muscle disease, but most of them had skin at the time of the study. This is showing you, this is the first 4 weeks. This is the treatment arm in blue. This is the placebo arm. You can see very rapid separation between the two arms. And these are with people who had more moderate disease. And then actually after 16 weeks, the patients got crossed over, everybody got active drug, and you can see that gradually the patients kind of came together in terms of the improvement. So you can see the placebo group started to improve and got very close to at the end of the study to where the treatment arm was. And so again, documenting that here, at least with this, that there wasn't much of a placebo response and that it seemed to really show good separation. And this was even true at lower scores. Like here you can see the patients who had really kind of lowish scores. And the same thing, there was pretty good separation, just not a very big difference in the deltas here. But it's interesting that it was able to capture this kind of change, even with people who had pretty mild activity. And so I think that, oh, actually, I'm sorry, that's damage. This is the damage score. So this is showing you that damage can get better. So this is the placebo, this is the drug. And what can happen is when you turn off the erythema, the damage gradually can improve. And that's what this is showing you. And then these are the patients who had lower activity in their CDASI scores to begin with. And you can see that, again, there was a separation here. So here it was like the higher scores, and here it was the lower scores. And again, the same kind of separation. And so this is, I think, good news for an instrument that can capture this kind of change. And I think that might be the end of my formal talk. And I'm really happy to take any questions. Okay. So I don't know. I can probably read the chat, but is somebody going to moderate and ask me questions?
So, Dr. Victoria, do you want me to take up the questions?
Sure.
Sure. Okay, let's start from the top. Just give me a moment. There is a lot of questions. Thanks to everyone for. So, Dr. Vinita Shobha asks, how soon can CDASI change? How frequently can we assess for research purpose?
Dr. Vijay, Dr. Mary Augustine will lead the
Sure. Okay.
Q&A. Thank you.
Yeah, hello. Yeah, thank you, Dr. Worth. That is a wonderful talk. So I thought before going to the questions with regard to, when it will change and the photography, I had a few questions on some of the areas that we were not very clear.
Okay.
Yeah, one is the nail fold changes. Yeah, you capture the erythema, you capture telangiectasia. What about just if they have just hemorrhage or small areas of necrosis only? If there is no erythema, there are no telangiectasias?
Yeah, I mean, I think I think a lot of times people have a hard time with the naked eye necessarily even differentiating. So if there's hemorrhage, I would consider that to be part of telangiectasias. Yeah, and I would capture it there.
Okay. What about cuticular changes? The rough
That's
cuticle.
not included. I agree with you. I mean, I think cuticular changes are so common, dystrophic, cuticles growing over the nail fold. We don't try to capture that. So many people go and get their nails done and so on. We did not include that. I mean, there are many things that can be included, but we only tried to pick ones, a few of them that we thought would be meaningful.
Okay. Then on the dorsal of the hands, you've written dorsal of the hands except the joints, and you have joints separately. So very often we find patients having erythema continuously throughout the dorsal of the fingers, hands, including the joints. So do we capture them in two different places?
Yes.
Yeah, with the joints separately and the other areas separately, right?
Correct. Yes. You would, because I know you get streaking along the extensor tendons and so on, but if it's over the joint, then you should assess that separately then from the dorsum of the hands.
Okay. And occasionally we find Gauthron's papules on other areas like elbows, knees. So do we just ignore them because there are no papules included in that other areas?
Yeah, it's pretty rare. I agree. We've seen it. It's
Very
rare. We didn't because we were lumping that together with the other body surface areas. And maybe I should share it so we can look at this again. Yeah, I mean, I think it would be going back to the instrument because I think that's sort of what we're talking about here. Sorry. Here. So, there's really no place to capture papules here, and Gauthron's not on hands, and so we don't try to capture that.
Okay. And what about ears? Like we had a patient recently where a lot of erythema on the on the ears, both ears.
Yeah,
Do we
we see
capture
that
them?
as well. I'm sorry.
Yeah, do we capture them? I mean, is there any way to
You know,
capture them?
we did not. I think you have to be consistent. I mean, one could argue, you know, if it's really significant, maybe to capture it in rest of face, because there really is no other area here. But I think you have to be very consistent in a given patient. I mean, I agree with you, it does happen.
Okay.
And you hate to miss it. So I would pick an area that like rest of face and capture it there.
Okay, okay. Then another thing that we see quite often is a lot of edema of the eyelids, as well as generalized
Yeah.
anosarca, for the whole body edema, which is quite
Right.
common, it's not very rare. So is there a way of capturing that?
Yeah, I mean, like the NXP2s, I think they often get edema. You know, I think we don't really capture that here. I mean, we sort of go more with erythema for the periorbital area. The anasarca often, you know, that's also really tough to evaluate.
Yeah,
So,
I know.
you know, I admit there's going to be things that we're not capturing. And I think they may be also hard to a little bit evaluate the change, although I agree the eyelid edema can be important, but normally, very often it's associated with erythema as well. So I kind of think it's okay just to capture the erythema. We did not try to include edema.
Okay. Then the few other areas, I guess we can capture it with nearby areas. You know, where we had doubt was like forearms, medial part of the thigh, lower chest, like say over the breasts. Those
Well,
areas.
here's forearm. Forearm is here.
Yes, yeah, the below, yeah, between your elbow and the wrist.
Yeah,
That
arm is it captures anything on the arm. It could
Okay.
be upper or lower.
Okay, okay. And the medial part of the thighs also, any part of the thigh will go into the thigh, right?
That'll go onto the leg, rest of leg and feet.
The medial
It's
part
just
of
the lateral thighs. I'm sorry.
yeah, yeah. The medial part of the thighs will go into the rest of legs, is it?
Yeah, you can
Oh.
capture it there.
All right. Okay. Okay. Yeah, I think that's pretty much, yeah, those are the doubts that I had myself. Okay. So
Yeah.
we will go to the questions which are there on the, sorry. I can't see the questions. One second.
If you go to the chats, Dr. Mary.
Yeah.
see.
I'm not able to go to the chats. What happened now, actually?
So one question was how soon can
Go to more.
how can this
There is a more there with 3 dots. Just click that and you'll see it.
It just goes on.
I can maybe address the first. I can do the first one if that's okay. It's about how quickly can CDASI change.
Yeah, I got it.
And I think I showed that with the 2 trials where it depends a lot on the drug, right? If you can get rid of if the drug is really effective, like with IVIG, you could see differences starting very early on, certainly by a month.
Okay.
So the CDASI really mirrors what you're seeing in the skin, and if you have a great drug, it's going to change quickly.
Okay. The next one is regarding photography. Any guidelines for to photograph the skin? Any standardized?
Well, the problem in the trials, you know, and in the drug company sponsored trials, they do have standardized often photography with Camfield, which is hugely expensive. So in an unfunded investigator initiated trial, forget it, that's not happening. And so, you know, you can take, you know, iPhone pictures, but the problem is the lighting can vary so much, and also just the image. So there are some standardized images that have been used for like pigmented lesions, but you know, I think it's just good to get pictures of all involved areas as much as possible with decent lighting and to look at the pictures right away. I mean, really the point is of the pictures is just, you know, like I would tell you in trials, very often there's baseline adjudication to make sure that the investigators know how to use the instrument and that that the patient has the right disease, that kind of thing. So it really depends on why you want the photos. I mean, you want some photos to show improvement if you're trying to do a drug trial. But, I think you have to assess, why you're doing photos. And then, if it's for verification of the investigator using the CDASI, that, I think you can get away with iPhones and decent lighting and maybe checking the photos to make sure they're okay.
Yeah. Yeah, Dr. Ramya had a doubt. How's the reversibility of poikiloderma used in trials?
It's interesting. It's not particularly used, but I can tell you that it does improve and it can be reported. The problem is, I mean, I think it's the activity is what you're normally looking for. But if poikiloderma is improving, then that's telling you something about the activity, So I think it's good to report both. And I think typically that it can be done in trials.
Okay. Yeah, I think Dr. Vinita is asking, should one use magnifying glass, just magnifying glass, hand lens, to look for telangiectasia? If you find it with a hand lens, it still becomes 1? Or is it
Yes.
go to 2?
Yes, it's a 1.
It's a 1.
And because a lot of people, everybody's got some different way of looking at the nail folds. And so I think that's not very standardized even that way. So I think it's just we've decided to make it more simple. If you can't see it with your naked eye, it's a 1. If you see it with the naked eye, it's a 2.
Okay.
I would say magnifying glass is really important for diagnosis, right? I mean, I find it so helpful to look at nail folds, but it's a little bit different than in a trial. Yeah.
Yeah. Telangiectasia could be damaged. That's the question. Yeah, telangiectasia, I think it goes into the poikiloderma. Yeah, it goes into the poikiloderma spectrum. So it will come under damage, right?
Yeah, it's in the damage side.
Yeah, I think somebody has already answered that. Am I missing something? Appears activity as well as telangiectasia appears in activity as well in periungual, in the periungual area. No, that's different. That telangiectasia is different. The periungual telangiectasia is different from your damaged telangiectasia.
Correct.
That's part of poikiloderma, right? Okay. Now another question is, what is the specificity of Gotrans?
Well, it's pretty good. We're doing a study now where we're looking at trying to develop better skin criteria. And the Gotrans papules are about as, and we did have control diseases that were mimickers of dermato, and that was like one of the highest differentiating factors was Gotrans. So in fact, the myositis criteria that were developed around 2017 or 19 looked at papules and macule. We have 3 skin criteria: heliotrope, Gotrans papule, Gotrans sign. 2 out of 3 of those you can make a diagnosis of dermato, and we're finding we want to include more variables. We're studying that now, but I think we again confirmed that papules and Gotrans sign are pretty helpful. Having said that, there's certainly other diseases that you have to think about, and it's not specific. And so when you're not sure, we will often do a biopsy to try to look for the differences. For instance, psoriasis could be over, joints and so on. So you have to keep there is a differential.
There's another, I presume it's a suggestion that mechanic's hand can be taken as damage index.
Yeah, I don't think so. I think it's part of the activity. I mean, if you do a biopsy of mechanic's hands, it has interface dermatitis. It has it has inflammation. I think it's part of activity.
Okay. About hyperpigmentation being reversible, is it with immunosuppression or with topical depigmenting agents? That is a question.
I mean, it's true that topical steroids can cause dyspigmentation, and in darker skin, that's a concern, and so that becomes a clinical judgment. Do you think that it's from the steroid, or do you think it's from the disease itself? Sometimes, if it's from the steroid, it may actually be larger, and more confluent than the actual original lesion was, and so there's not it's a clinical judgment about that. It can be hard to tell the difference.
Dr. Mishra, isn't pink, red, or dark red, depending on the duration of the lesion. Early ones could be pink and later ones red or dark red, and it's not exactly depending on the degree of inflammation. Yeah, he's suggesting that it depends more on the duration rather than the degree of
Yeah. I
inflammation.
don't think we have evidence for that, actually. I mean, we see people early on who have red lesions. And when we've done biopsies, at least in lupus, there's a correlation between the degree of erythema and the amount of inflammation. So, I just think different people have different intensities of inflammatory cells that are driving the erythema that's there. I don't think it's a matter of how long they've had it.
Okay. And in Asian Indians, difficult to identify pink or even red lesions despite activity due to background color. That is a problem that we face. Yeah, but like you said, it is difficult.
Yeah, I can't fix. Yeah,
Yeah.
we have to all recognize that's a problem. But if you want to include skin as something that's a pretty sensitive indicator of improvement, we have to do the best we can do. And that's why I think it's helpful to be able to assess many different body surface areas, because in a person that has fairly widespread dermata, you're going to be able to see areas that are, more involved and have more erythema, and those will be the areas that'll be easier to evaluate for change. But if you can't see any erythema, that was probably not the right person to put in your trial.
Yeah. Yeah, there's another question. What is the difference between poikiloderma and salt and pepper pigmentation in scleroderma?
Well,
yeah.
I mean, the salt and pepper is, it's usually more perifollicular. It's more usually in the setting of sclerotic skin. I mean, you're right. I mean, could be a differential for that, but usually there are other features that help you figure out, whether this poikiloderma in dermato or whether it's more from scleroderma with the salt and pepper. And in terms of the biopsies, I mean, they look really different, and mostly because of the sclerotic changes.
Yeah, even clinically, there is in dermatomyositis there's an underlying dusky erythema. It's not just pigment change. In scleroderma, it's just pigmentation. That's all. It's just a hyperpigmentation with tiny spotty hypopigmentation.
Yeah,
it is different.
Right.
And there is no atrophy. Yeah. It's only pigmentary change. Here you get atrophy. A little bit of atrophy also happens in dermatomyositis.
You can get scarring, yeah. I think you're right. I think clinically it's usually not a big differential. Usually you can tell the difference.
Yeah, the next question is, which damage parameters improved on IVIG?
So, I mean, I think the most common damage that we see in adults is going to be dyspigmentation. And so that would be, I don't know that we broke it. You can't really break it down between telangiectasias and it's more just poikiloderma. And that's the one that really improved. I don't think we have much evidence that IVIG does much for calcinosis, and the incidence of calcinosis in adults is not that high. So it's mostly going to be driven by the dyspigmentation, poikiloderma.
Okay. In the periangular pictures, do we score erosions? In the periangular area, do we score erosions?
Yeah. No, we don't score those. Okay. Normally, that's not the body surface area that we're evaluating for erosions. That's almost everywhere else.
Yeah. Another, again, suggestion, I think, best instrument in India for nail fall capillary study.
I'm sorry?
I think it's a question. Probably, what is the best instrument in India for nail fall capillary study?
Well, I mean, a lot of people do nail fall capillaroscopy. I mean, that requires, equipment and so on. I like dermatoscopes. That's what I routinely use in my practice. I can keep it in my pocket. I can really, see quite well with them. And so I like dermatoscopes.
Yeah. Then telangiectasias at upper eyelid, where do we classify, and does it indicate a severe disease? On the upper eyelid.
So yeah, I mean, the telangiectasias, and I think I had that one example, those are on the damaged side for the eyelids, and they're considered more of a damage feature, and rather than an activity feature.
Okay. Then I think somebody has given a suggestion. iPhone is the best and most practical way to photograph. DSLR require much more effort and skill for macro photography. Not worth the trouble. Okay. Dr. Vinita has another question. Does speed of skin rash improvement reflect in overall long-term outcome of dermatomyositis? If
Well,
the
I mean,
improve faster, yeah.
yeah. I mean, I think that, I mean, one thing is that not everybody responds to all our therapies, right? And so I think the skin is a pretty good mirror of what goes on internally. I actually think the muscles often get better and the skin is still there. But I think that to the extent that, for instance, if somebody's on methotrexate or mycophenolate mofetil, they get better quickly in the skin. I think that's a very positive sign, but we don't see that in everybody. So, so I think in the people where it's not working, you may have to switch therapies, and we often have to do that.
Okay. Again, there's another answer. Mechanics hand resolves completely, and so is activity. It is considered as an activity.
Yes.
Yeah. Sometimes it is nodules, not papules present over the joints. What is it suggestive of? I think it's the Gotran's papules that you're referring to.
Yeah, I mean, I think that it depends on a lot of factors, right? I mean, there's so many causes of nodules, and so I think some papules can be fairly marked, and if it's in the setting of dermato, that's great. I mean, certainly you can get rheumatoid nodules, you can get MRH. I mean, there are other causes of nodules, OA. So, I think, but if you think it's you can see kind of biggish papules in patients with DM. And, I'm not sure that they're nodules per se, but, because nodules kind of implies a fairly large lesion.
Unless they are early calcinosis, I guess, before it ulcerates.
Yeah, that's the other thing. Yeah.
Then what is the best use of capturing damage to differentiate from activity or not? I mean, what is the use of capturing damage?
Yeah, that's a great question. It is the reason we did it or thought about it is so that people have to think about, is this activity or is this damage? And it sort of forces one to think about that a little bit, because the telangiectasias can be, like really think about which one is it. And I also think it's really interesting that damage in the skin can improve. And so it's another marker of potentially the downstream effect of a therapy is that the changes improve. So I think those are two things that are worth considering.
Okay. There's one more question. How are periungual telangiectasias scored? Which I think...
okay. So the telangiectasias, if they're with the microscope, or with a dermatoscope, then it would be a 1. If you can see that with your eye without any help, then it's a 2.
Okay. Has any local therapy been found effective, and also with systemic immunosuppression has been found most effective for cutaneous predominant dermatomyositis, refractory to conventional therapies?
Right. Well, that's like a whole lecture. Yeah, I mean, I don't, there's a lot to think about with this. I mean, sometimes we even use hydroxychloroquine, acknowledging that many patients can get a rash with hydroxychloroquine, but it can be effective in about 20% of patients. And if it is, then you don't have to go on to immunosuppressives, such as methotrexate or mycophenolate mofetil. I don't find that azathioprine is all that helpful for the skin. And so, but methotrexate and MMF don't work for everybody. If that doesn't work, or as a bridge drug, I sometimes use IVIG. There's, not much data yet in JAK inhibitors, so it's hard to get too excited about them, and they're expensive and they have side effects, and how long are you going to continue them? And, I was part of the anti-interferon beta study, which is an infusion drug, maybe will eventually be a sub-Q drug. That works beautifully for all dermato. So if their trial phase 3 works, then we may have some really new approaches, which will be very helpful.
Okay. I have one more question. If you have calcinosis, which is deeper down in the muscle plane, is it captured along with these?
Yeah,
Muscle
any kind of calcinosis. Well, I mean, I think it's hard to assess if it's muscle or you know, in the dermis or subcutis, unless you do something like an MRI or something. So I think, and by and large, I'm sure you can get calcified muscle, and maybe I wouldn't capture it was only in the muscle, but most of the time it's going to be in the skin.
Okay. Yeah, I think that's all the questions that has come so far. If anyone else has any more questions, I guess you have to put up your hands or add to the chat. I hope I've not missed anything. Yeah, there's one more, sorry. Oh, yeah. Excellent session. Great plan. True. Very good.
Thank you.
Very good.
All
Thank you.
right. Well, great questions. It's great to get so many good questions.
Dr. Vijay, would you like to take over?
Dr. Mary?
Yeah, Vinita.
This is Vinita again. Thank you very much, Dr. Victoria Worth, for taking time out to talk to us this morning for you and this evening for us. And a lot of students actually joined in today, and we are hoping that your lecture today has empowered a generation of rheumatologists in India in terms of assessments of the skin in patients of dermatomyositis. So thanks a million once again, Dr. Victoria Worth, and we really appreciate your time and your effort. Thank you again.
Great. Thank you very much. All right. Bye-bye.
I thank Dr. Mary Augustine for wonderfully handling all the questions, and Dr. Mishra, thank you, sir, for joining in today. And lastly, I must thank all the attendees who actively participated in today's session. And lastly, Dr. Vijay K. Rao for helping us with the technical aspects of this Zoom platform. Thanks a lot, everyone. Thank you very much.
Thank you. Thank you, Vinita.
Thank you, Vinita. Thank you, Vinita, for organizing this. Very nice.
All right. Bye-bye.
Bye-bye, sir.
Bye.
Bye, Dr. Mary.
Okay, bye.
Bye.